Okay, well, welcome everybody. And as we wait for more people to join us, I'm June Chaos, and I'm a disability policy consultant and contractor for CFILC's California Disaster Coalition. So as we wait for a few more people to join us, just wanted to review with you. We got 2 calls lined up for the next 2 months. We have a call on May 13th, which should be fascinating. And that is the intersection between health plans and their emergency response and assistance to folks with disabilities. And that's going to be IEHP, the Inland Empire Health Plan. I'm talking about how they use geographic information systems, GIS, in terms of protecting people in emergencies, using those capabilities and using the kind of data that's generated to be helpful and meaningful in identifying people with high needs, such as mobility device users, DME users, durable medical equipment, and those dependent on items like temperature controlled medication, clean air quality, backup power, etc. So how they use GIS and how they involve the many departments in the health plan in helping to respond and work with people in these emergencies. There's software coordination with many different departments. So that should be intriguing in terms of understanding of a promising practice and its elements. And then in June 10th, we have a focus on emergency power planning. What works and what needs work. And that's going to be the California experience. We're getting a lot of questions around the country as to what's going on here in California with the power shutoffs, the PSPS, public safety power shutoffs. So we're going to talk a lot. Christine Mills from CFILC will be presenting, and she'll be talking about the lessons to apply, the short-term and long-term solutions, and really the future advocacy roadmap, the short-term, the mid-term, and the long-term plans needed to help address some of these solutions from a legislative, regulatory, utility, community partnership, and existing technology perspectives. So that should also be a very interesting discussion and presentation on June 10th. So today we have a nice crowd. I see some friends. Good to see you all. Today we're going to have a discussion on homelessness and disability. And in California, that's going to also involve some discussion of RoomKey and HomeKey, COVID-19 issues, cooling and warming centers, personal assistance, including IHSS, and kind of maximizing Medi-Cal to support seniors and people with disabilities at high risk of homelessness. You know, what's going on out there? What's working? What's not? What do we need to be aware of in terms of our future planning and advocacy? So Lisa is going to be our presenter, and our approach today is casual and comfortable. So if you have questions, just go ahead and pop them in chat or use the function in the participant list to raise your hand and we'll call on you. We're gonna, again, feel free to raise your hand anytime during the discussion. Lisa does best to take your questions as they come in. At the end of the discussion today, we'll do a short poll to get your feedback. And just a reminder, we learn a lot from you in terms of your feedback. So please be sure and hang on to take that poll. And if you're not able to do it that way, we'll also post a link for the same questions that will occur in a SurveyMonkey poll. So a reminder, this discussion will be posted at the Disability Disaster Access.org website, probably by next week. So Lisa's a good friend and a great resource in terms of this area. I've asked her tons of questions about these topics in the past, so I know she goes deep into her understanding, and I'm going to turn it over to Lisa to do her own introduction. So Lisa?
Thank you, June. Good morning, everybody. Thank you, CFILC, and all of you for inviting me to join you today. I'm very honored to be having this conversation, especially at this point in time, given what we've been through over the past year and are still in the middle of. So I will briefly give you a little bit about my background. Then I want to know a tiny bit about who you are. I will just ask you to use the reactions to give me a sense of who this audience is. I have an idea, but just a little more. Then we'll talk about some of what we've seen over the past year in terms of emergency response regards to people experiencing homelessness, some ideas about how existing systems could better serve people experiencing homelessness in emergencies, and we'll also talk about some possible solutions, some possible paths forward, some opportunities for advocacy. But really, I would prefer this to be a conversation among us. I see some familiar faces. I see old friends. I see new friends. Some of you I've worked with over the years. Some of you I haven't yet met. So very, very happy to see all of you here. Megan's going to be monitoring the chat. So if you do have questions, you can pop them in the chat or raise your hand and through the reactions button, and we will unmute you and ask questions. But please, if you could stay on mute if you're not speaking, that'll help with background noise. So let me just give you the briefest introduction to who I am and why I'm here. Why am I in this Zoom room today? You know, I come in my family. I come from a disability advocacy background. It was part of my upbringing. It was part of what I was marinated in from the time I was born. I have a family member with a significant disability, and it's just always been part of my consciousness that we have to advocate, we have to speak up, we frequently have to fight, and we have to organize and be a community in order to bring about change. So that's what brings me to this work, but professionally I've mostly worked in the Medicaid world, looking at how Medicaid healthcare systems can better serve older adults and people with all sorts of disabilities so that people can get the services they're entitled to and the support that they need to live as independently as possible in a community. That has always been my personal goal, and I've managed to forge this career where I get to do that within Medicaid systems. And now I find myself at this really interesting intersection because of this homelessness crisis we're in here in California, that my background in healthcare and disability advocacy and advocacy for seniors and housing and homelessness and home and community-based services and independent living are all coming together right now in the midst of this COVID emergency. It's been really kind of a unique opportunity to bring all that and merge it and see how we can use, all of us collectively can use our different backgrounds and experiences to respond right now. So I do consulting right now, but I used to work at a health plan, as I know some of you on this call have. And I was at LA Care Health Plan. I'm in LA County. I know that you are from all over the state, but I'm maybe all over the country. I'm not sure. But I'm in LA County, and I worked at a health plan here called LA Care Health Plan, and started building relationships with independent living centers about 15 years ago. And really, there hadn't been no relationship prior to that between independent living centers and Medi-Cal health plans. So I got to work with CFILC and so many of you in LA and around the state back then, trying to think through what this relationship might look like. So this group can also continue to think about that. And as June said, that will be a topic, I believe June said at the next meeting of this group, is how to maximize those types of relationships. And I know there's some people on this call like Ben and others who also have a lot of deep experience around that. So that's me, but let me now find out just a bit about all of you. If you are able to use the reactions button on your Zoom, can you tell me how many of you currently work at independent living centers throughout the state? If so, give me a thumbs up in the reactions. So, okay, I see some people work at ILCs. Yep. Okay, excellent. All right. And if you work at an advocacy organization that advocates for policy for older adults or people with disabilities, can you give me a thumbs up? Okay, great. If you are here as a consumer advocating for yourself or loved ones who advocates for policy change, give me a thumbs up. Okay, great. And if you work for maybe a government agency or another nonprofit that it works in the field of emergency services, disaster services, thumbs up. Okay, got it. We've got quite a spread of people. If there's any category that I missed, just pop it in the chat and I will take a peek at that. Great. Okay, so I have now a sense of who I'm talking to above and beyond. Okay, so again, any questions, please put them in the chat or raise your hand and we will call on you.
Megan, Katie has her hand up.
Yeah, Katie, go ahead. Katie, do you have a question?
I was just raising my hand for a disability advocate.
Oh, beautiful. Thank you.
Sorry.
No worries. Thank you.
In
Thank you
the
for
chat,
joining.
folks are saying someone's from the Department of Rehabilitation and then hospital working with older adults and the disadvantaged.
Awesome. Thank you all for speaking up. I appreciate that. Okay. All right, so we're going to jump in and talk about what happened over this past year, which in my mind, I call a convergence of emergencies. We had this emergency of the COVID pandemic, have, but it was a convergence of emergencies because COVID converged with the emergency of poverty and the emergency of racism, and it converged with the very present emergency of homelessness, which has been an emergency for a long time, but the pandemic really highlighted even more the disparities and this crisis we're in, where unhoused people are at such risk of really, catching the virus, dying from the virus. So this convergence of emergencies led to this project called Project RoomKey. I don't know if this group has talked about it or if I should give I'll give a very brief overview. June, I should explain it, right? Okay. So Project RoomKey in California, it was funded by FEMA, which I know you all know what FEMA is. FEMA gave the state some money to basically rent hotel rooms throughout the state for people who are homeless, who are at very high risk of getting COVID or dying from COVID. So what we found is that this program, which is unprecedented and rather extraordinary, was rolled out very differently depending what county you're in. And I didn't come today with statistics about how many people got hotel rooms or this or that. Those statistics are available, but because really I want to talk today about some specific issues that arose and how they were addressed differently for people with disabilities who are experiencing homelessness in different parts of the state. And what we can, these are not lessons learned, because June has educated me that these are not lessons learned because we haven't learned these lessons yet. These are how can we be better prepared the next time this happens, because this will happen again. So what can we take from how this happened and make sure that we're better prepared next time around? So Project RoomKey, again, are hotel rooms all around the state that were made available to people who are homeless, who are at very high risk of either getting COVID or dying from COVID, which means predominantly older adults who are very high risk, or people who had underlying health conditions that meant that if they caught the virus, they would be at much higher risk of death or serious disease. So these hotel rooms went live all over the state, and they were provided free of charge to the hotel guests, to the people experiencing homelessness. And the funding went for the rental of the room, and meals were delivered, and support services were put in place to varying degrees. So specifically the topic that we are going to talk about, and there are several advocates on this call who were part of talking about this and working through solutions, is that among the population of people experiencing homelessness, you're probably aware, a high percentage are people who have disabilities, who need help with their activities of daily living, like getting dressed, taking a shower, who have cognitive impairments, either dementia, traumatic brain injury, intellectual and developmental disabilities, serious mental illness, and physical disabilities. So there's a broad range of disability, the prevalence of disability among homeless individuals. So when these hotel rooms started opening around the state, and local homeless service agencies started reaching out to their clients or reaching out to people on the street to try to invite them into these hotels, we saw this roll out very differently in two different places. First, I'll tell you about San Francisco. In San Francisco, they opened, I believe, 7 hotels to house homeless people at high risk of COVID or of dying from COVID. And San Francisco already had some structure in place to immediately help those guests with their activities of daily living through an IHSS a specific IHSS program. Are you guys, IHSS, is that an acronym that most people are familiar with? IHSS, in-home supportive services. Those are personal care attendant services funded by Medi-Cal for Medi-Cal beneficiaries to help with getting dressed, taking a shower, other activities of daily living. So in San Francisco, when these hotels opened and homeless individuals were invited in, many of them, I believe about 10% of them needed this kind of assistance. So the partnership and collaborations that already existed in San Francisco quickly deployed some personal care assistants to go into those hotels and help those individuals who needed assistance while they were sheltered in these hotels. Because these hotels really are shelter. And I know shelter is something that you all talk about in your emergency services world all the time. And while the word shelter wasn't attached to Project RoomKey, they were sheltering people who were unhoused at a time of great emergency and a convergence of emergencies. So that's how San Francisco responded. So let us cut to, as they say here in Hollywood, let us cut to what happened in Los Angeles, which is between 30 and 40 hotels went live here in LA. And the agencies that were put in charge of determining eligibility for hotel guests did not have any system in place to meet the needs of people with disabilities who required assistance with their activities of daily living. And so the application forms and screening process here in LA specifically excluded people who needed help with their activities of daily living, like taking a shower, getting dressed, which, as we know, probably, and we don't even know this for sure, meant that a lot of older adults and people with significant disabilities were passed over for this shelter program and were not offered hotel rooms because they were specifically excluded, because there weren't systems in place to meet their needs. So advocates got wind of this, and a group of advocates, some of them are on this call, including Christina from CFILC, got together and raised this issue and brought it to the attention of the local homeless services agency, who then issued a retraction of that policy and also hired some caregiver agencies to come in and assist some people in some of the hotels. So that is the first, not quite lesson learned, but it's the first thing we need to take with us into the next emergency, which is that advocates had their eyes open, they were watching, they spoke up, they collaborated, they came together to raise this concern, and they jointly approached the agencies that were accountable and said, this is unacceptable, this must change. So that will be a key takeaway for all of us. But it didn't happen until these advocates really came together and realized that they were all hearing the same stories through their sources and decided collaboratively to present sort of a joint effort. And it was through an advocacy coalition here in LA called the LA Aging Advocacy Coalition. So it was specific, it was a coalition that already existed and it had some relationships and some brand recognition. So that would be the question, is for people locally, what coalition, do you have a coalition of disability advocates locally? If you don't, might it be worthwhile to have one that you can quickly deploy in the midst of a crisis that can keep its eyes and ears on these types of issues and can come together to collaborate and speak up if you see that things are not happening the way they should? So I wish I could say that here in LA that the problem was solved, but it actually wasn't. We don't know how many people were passed over for Project RoomKey because this policy was once in place. And the thing is that Project RoomKey is a path towards permanent housing through another program called Project HomeKey, which is the next step where there's funds available to help those hotel guests get housed permanently. So we need to know if people who need help and assistance with their activities of daily living, are they going to get housed permanently through this? Are the solutions going to follow them? We have concerns. I have concerns about whether these housing solutions are going to include or exclude people with different levels of disability. So that's another thing to look at locally, and a lot of this is local, but some of it is also at the state level. And I know we have some of our state partners on the call today, so I'm sure we would all love to hear at some point your ideas or suggestions for for us all to be better next time. So I'm going to stop about those two case studies about San Francisco, LA. Are there any questions that you all have about what I just said, or any additional thoughts that you want to contribute on those two scenarios, whether you were involved in these efforts or whether you just have ideas or questions about how that unrolled? Anybody, questions? You can either raise your hand and we'll unmute you, or you can ask in the chat. Megan, are you seeing any questions in the chat?
No, I'm not right now, Lisa.
Okay.
We do have, Joseph has his hand up.
Joseph, please, you can go ahead and mute yourself. Hi, Joseph. We see that your hand is raised. If you
Okay, yeah, yes. Yeah. What I'm wondering about is LA does have a IHSS, a large IHSS program. So I'm wondering, where was the breakdown in regards to resources? Was it that have we looked at the care providers? Are they mainly family members? Are they independent? It's, again, LA's got a large program, so I'm not quite. I understand that the system broke down, but what is it that San Francisco had in terms of structure that LA didn't have?
Yeah, Joseph, excellent question. So, what San Francisco has is a nonprofit organization that offers IHSS to people who have difficulty navigating the independent provider mode of IHSS. Independent provider mode of IHSS, as you know, is where people have they choose their own caregivers, they hire them, they train them, they supervise them, they can fire them if they want. It's a deeply held value within the IHSS program that I, as a disability advocate, I completely value that and honor that. And it should be preserved at all costs for people who want that type of agency over their personal care assistants. But what we're seeing more and more is that some people can't do that. They don't, because of cognitive impairments, because of serious mental illness, because of an intellectual disability, or because they've been living on the streets for 17 years. They just don't have the wherewithal to navigate that kind of responsibility. So in San Francisco, there's a nonprofit that people can choose to get their IHSS through, and instead that nonprofit will help them find a personal care assistant, and they offer some training and some supervision. The consumer still self-directs their personal care. They're still very involved, but they have help finding a caregiver. So in LA, we don't have that kind of program set up. We do have a very robust IHSS program, and we have our Personal Assistance Services Council. Our IHSS public authority is highly involved and engaged, but it also wasn't set up specifically for this. And the consumers who went into the hotels, they weren't assessed for IHSS. They hadn't been granted IHSS hours. They'd never had IHSS before. They didn't know how to find caregivers. So none of that existed at the beginning. It all had to happen, but there was no protocol in place to activate it. I mean, just Joseph's, like, even in the very beginning, when someone checked into a hotel, in my opinion, immediately there should have been an IHSS assessment, and they should have been plugged into any of the above systems. But that just wasn't in place. So that's where one of the main breakdowns was. And that's something that we need to take with us in the future. And you guys may already know this, but IHSS, even though it's in-home supportive services, it is available to people that are experiencing homelessness, even if they're not living in a home. If someone's in what we call interim housing in a homeless shelter, they can get IHSS in a homeless shelter. Those protocols have been put into place. So the question, and this goes into our next topic, is how can IHSS help people who are homeless get housed, and can it actually help prevent people from falling into homelessness? And how can we maximize IHSS to help people live their best lives, the most independent lives that they can, with the help of this existing program? I see some hands are raised. I didn't see which went up first, so I'm gonna call on Vidal first. Vidal, you can unmute yourself.
Thank you, Lisa. Good morning. I'm an advocate for resources for independent Central Valley system change advocate, and I'm also part of the DOOM network with CFILC advocates throughout the ILCs in California. So my question is regarding what happened in San Francisco regarding being eligible. Did you have to be eligible when you went into the hotel rooms under RoomKey? Did you have to meet the criteria for eligibility for in-home supported services, or was it just automatically specifically done or given to you because you were in this homeless situation due to COVID? Over.
Right. So Vidal, what in San Francisco, because they wanted to move fast, because this was an emergency, they didn't wait to assess people for eligibility. They just immediately deployed personal care attendants in those hotels to provide assistance to people who requested it. Boom, just right away. Then what they did is later they went back and they did those formal assessments. They got people approved for IHSS, and they actually, I'm pretty sure they backdated that eligibility so that Medi-Cal would pick up the cost. But from the beginning, the city just said, we will pay for this right now because it's essential, because it will get people the support that they need in these hotels on day one. I see that Deborah has a hand up. So Deborah, if you want to unmute yourself.
Yeah, I'm Deborah Kaplan. I work at San Francisco in the Mayor's Office on Disability and have watched all this. And I think San Francisco at this point is fairly unique because there is such a strong relationship between the county and the Homebridge, the agency that was able to just step in and figure out how to make this happen very, very quickly. And I think it's taught a lot of us inside that a lot of the sluggishness of the bureaucracy is not actually necessary. It's not impossible to function without it, but you do have to have the city and the county in this case standing behind you, and the county did. I just would also just, I think, you know, in talking about this issue, in framing it in this way, you know, the IHSS independent provider mode, I think, is really set up to work for the people who I think are sort of the most privileged in the system and who are able to manage their own and who prefer things that way. And but it is absolutely important to preserve and look at what elements of that can be brought into other parts of the system. But I think focusing on this particular issue is just extremely important. And I would venture to guess it's sort of like universal design, in that if we can get IHSS to work for homeless people, there probably would be improvements for everybody within the system as well. And that ought to be sort of the priority in order to sort of help fix a system that for many people is just not working very well.
Yeah, thank you, Deborah, and thank you for all that your city and county have done around this. You've really been leading. You've been leaders, and you've shown leadership. One thing that I think this group could potentially help with is reporting on what went on in your counties, in your localities. You know, we have some stories about San Francisco, LA, San Diego, but we don't know statewide what went on in Project RoomKey, what the eligibility was. Were people with disabilities included, excluded? Were they offered sufficient services? There hasn't been really a statewide survey of that. I wonder if I don't know if that's something you all want to look into among your local partners and just kind of ask questions. Because again, what we're trying to do here is figure out how to be better when the next emergency hits, whether it's fires or the next virus or earthquake. You know, any disaster that is on the horizon, we'd like to be better prepared for. So, are there any other hands up or any other questions in the chat? I don't see any.
One question in the chat. June wrote, does HomeKey use the same age and eligibility criteria as RoomKey did? And can you repeat what those criteria were?
HomeKey is for people who were in RoomKey and are going to be shifting to HomeKey. And Patty from Justice and Aging is here, and she knows more about this than I do. So Patty, if I say something that isn't completely on spot, will you please speak up? So the criteria, again, the criteria to get a project hotel room, temporary, were someone who was experiencing homelessness and was at high risk of either dying or getting very sick from COVID, which meant either people age 65 and older or people under 65 who had one of a specific list of health conditions, underlying health conditions, that made them eligible for those temporary hotel rooms. And then Project HomeKey is counties are purchasing properties to turn into permanent housing that they will then offer to some of the Project RoomKey hotel guests. But as of now, I don't think there's enough Project HomeKey sites or rooms to house everybody that was in the hotels. But some people who are in the hotels have been moved into different types of housing over the past year. Again, I don't know what numbers. I assume also some people have left the hotels and returned to homelessness. But there are evaluations going on looking at how successful Project RoomKey was in both protecting people from COVID and also helping them move to more permanent housing situations. Patty, do you have anything additional to add to that?
And Lisa and Patty Jr., just to probe that question a bit more. So those underlying conditions, specifically, it seemed that that caused some issues in the disability community in terms of, who was and who wasn't. Patty, can you help us with those more specifically?
I can tell you that they used the CDC guidelines and they identified, a set of, COPD, diabetes, I believe it was type 2, some other ones that were identified initially by CDC as putting you at greater risk of sort of comorbidity. And those, they kept shifting, and each county interpreted them their own way. But I know that there was a lot of concern and legitimate concern about whether it captured those people who were truly most at risk living on the streets. And I think it was a very imperfect set of criteria, and then how it was administered varied greatly county to county. I just wanted to circle back to Lisa's description is spot on as usual. And the other piece of this, the question that is raised is, how is Project HomeKey, which is the successor program to Project RoomKey, and it is your pathway to possibly permanent housing, whether it's permanent supportive housing or a Section 8 subsidy or one of these sites that have been bought through Project HomeKey and is going to be turned into permanent housing of some sort. I think that we see this as a really important gateway, and at least in LA, and I'm curious what others are hearing around the state, we are hearing that they are adopting the same kinds of restrictive criteria around people who need help with personal care or their ADLs not being eligible for HomeKey. They're identifying that as a high acuity medical need that prevents you from getting this established pathway to housing. So that's very concerning. And I think that because the governor and the federal government's American Rescue Plan is putting a lot of money into this right now, we might think, oh, this is all winding down, but I think this is actually still a very ongoing opportunity. The governor just allocated some more money for licensed care facilities to expand. He also identified in the master plan for aging building on the success of Project HomeKey to expand the supply through that model. And so I think we want to be sure that we're at the table discussing how you build an inclusive model of bringing people who might need additional assistance into Project HomeKey, addressing physical accessibility of the units that are being purchased, addressing other support services, wraparound services like IHSS, but not only IHSS, that might support people living as independently as possible in the community.
Yes, thank you, Patty. Any other questions? Something that I would just like to see your reactions to. When we in LA discovered this Project RoomKey situation, I reached out to one of our local independent living centers, because we have a lot of them. And I asked if they had any success referring their clients, their homeless clients, to Project RoomKey to get hotel rooms, to get this temporary housing. And that ILC said they had zero success. So of our ILC partners that are on the call today, do any of you have any stories about either success or not success in trying to get your clients into Project RoomKey in the midst of all this? Anybody have any experiences to share about that? I see 2 hands raised. So let's start with Joseph.
It's really a different question. I guess I'm thinking of the next disaster. We don't know when or where or what type of disaster we're talking about. What I'm thinking of in terms of a disaster like a massive earthquake that would take out our infrastructure. Now, what will that mean for people who are vulnerable in terms of homeless, the elderly, and connect that to the issue of medications? How are they going to get their medications? How are they going to get food with an infrastructure that's collapsing? Perhaps even the airports may or may not be operating. So LA, Southern California will be very much isolated. So my thinking is, are we looking at linking with organizations like the federal government, the United Way, American Red Cross, regarding maintaining resources that people are desperately going to need during that type of disaster? If you're a diabetic, you're still going to need your insulin. If you've got cancer, you're going to need whatever medications you're taking. How are people going to get access to those medications? And so I was just wondering, imaginative ideas about having stockpiles, not just looking at LA or LA County, but look at Southern California as a region, not just as an individual counties, because we tend to do that a lot. And where LA goes, the whole region tends to go. So if we look at it from a region, at the very least, I think these are issues that we really haven't paid much attention to.
Yeah, thank you. Thank you for that, Joseph. That seems to me the purpose of this group. Am I right? That is the goal of this group, is to come together and address all of the potential situations that could arise in the midst of an emergency, including medications and medical equipment. Yeah. I see that Keith, you have your hand up. You go ahead.
Yes. Good morning. My name is Keith Williams from DCRC. I think for my personal situation, it was the eligibility and the information that was kind of like given to those who was helping the people on the front line. A lot of the information was kind of confusing, and, like you said, different eligibilities, different counties. People usually in a homeless situation are going from one county to the next. So I just think somehow they've got to find a way to be able to get information to those who have to get the information to the people a little bit more properly, or channel it some other way, because that confusion caused a lot of misinformation, in my opinion. That was it.
Well, thank you, Keith. And tell me again where you're located.
Disability Community Resource Center. We're in West Los Angeles, Venice.
Formerly known as
West Side Center for Independent Living. Yes. Yes, indeed.
Yeah, we have someone on the Zoom who maybe was our executive director a long time ago.
Oh, okay. Where is she?
That's June.
June. Hey, June. Hi.
Yeah, thank you, Keith. I also see in the chat, I see that Wendy said that in her center in Reading had some success with Project RoomKey with getting a client who had cancer into a hotel room. So that's good to know, Wendy. Those are the, amidst all this, amidst the failings, it's good to hear that there are some successes. And it is true, Project RoomKey has sheltered thousands of people, and that is good. But our concern, again, is that people were overlooked or excluded from the get-go because of some eligibility criteria that were unacceptable. So thank you for sharing that story. I see some more hands up. I'm going to call on Sherry.
Hi, good morning. Yeah, thank you for this discussion. So I'm Sherry Burns, the Executive Director of Silicon Valley Independent Living Center serving Santa Clara County. And there were some positive things and some not so great things that we did here. They decided to do a centralized hotline, basically, for people to apply for consideration, either to be put into a mass care and shelter site with distancing or in hotel and motel rooms. And we had, even though my agency has a service contract with the Office of Supportive Housing here, and we've had in place for the last few years, and we're working with folks with disabilities who are homeless and moving them into temporary sheltering within motels and hotels while we address their long-term independent needs, and moving them into either permanent supportive housing or housing that they can afford if they don't qualify for PSH. The county seemed to have forgotten that we were a resource available to them for assessment. And we kept saying, I felt like Horton Hears a Who, is like, I'm here, utilize us. But they were just it seemed like they were so inundated and out of their element, and that they could not think past the end of their nose as far as utilizing some of their larger partners to work on Project RoomKey. And so we often had to advocate very strongly for specific consumers to be moved to the top of the list for consideration for motel and hotel stays outside of our small contract with the county. They are doing a much better job now, though, as they're moving people from RoomKey into HomeKey, and that they are utilizing our case managers to do the assessments, to work with the folks to build up their independent living skills, to make sure they have their benefits that they're eligible for in place, as we're helping them move them into then long-term housing. So that just started recently, though. But the whole initial temporary housing situation was kind of a mishmash, not handled as well.
Yeah, well, thank you, Sherry. I'm glad to hear that it has gotten better. I think one of the key things that I heard you say is that the agencies that were responsible for responding to this emergency just didn't know that ILCs were out there, and didn't know the types of services and supports that ILCs can offer. So I would say, tell me you guys what you think, establishing those partnerships beforehand and putting those referral pathways in place prior will make it easier when the next crisis hits for them to know who you are and how they can call on you, and vice versa. So that would be an assignment, I think, for all the ILCs and other types of agencies to form those collaborations in advance and have some of those relationships established. So you're not trying to forge them in the midst of all this.
Right. And it definitely helped, even though we had the relationship, they kind of, were a little bit too narrow in their focus. But now they realize, looking back, that they missed an opportunity, and they are now integrating us into their service coordination for HomeKey. So that's much better.
That is. Okay. All right. So someone from Talmadge House, I believe you had your hand up. Did I see your hand up?
Yes, my name is Talmadge Charles. I'm a system change advocate from Disability Action Center in Chico, California. When RoomKey first started, it was just as the individual just said, a lot of agencies didn't come to the ILCs. So when people were turned away that had important healthcare needs, then they came for advocacy. So we had to advocate and contact and figure out why they were turning individuals away who had healthcare needs or needed support services, could not get into the RoomKey. So we had to start learning to advocate and then communicating and reaching out. And then as we reached out with we partnered 211 partners with us, and we helped communicate with each other to make this go clearer. Once we realized that there was a break in communication and the information was faulty when it was first coming out, not clear, not distributed to all the agencies fairly and equitably, so that we can provide this information to everyone, so we can empower them. They were running around blind and just taking no and running back to the streets. When we have, as you say, these ILCs in each county or city, but each county and city is ran differently. But we did run into our difficulties, but we ironed them out as a city and a county right now, and trying to make it work better with this RoomKey transitioning into Project HomeKey. Over.
Got it. So Talmadge, what would you do differently next time?
What I would do is, whoever has the contracts, and we would incorporate the ILCs to have advocacies on deck online to help individuals that cannot mitigate for themselves, who have these DD issues, dual diagnosis issues, or developmental issues, who cannot speak for themselves clearly, who get turned away just for judgment. So we got to figure out how we can keep a contact list on who we can reach out to, who each agency or what each hotel can reach out to if this individual comes for maybe we need verification, or maybe we need, as you say in San Francisco. Not every county has the funding to go and just say, okay, we're going to put you in and we're just going to provide a support for you. There's not enough people to do all that paperwork and all that, enough people to do that intake. We got to put more information out to look for volunteers or people to help during these crisis times, because in order for us, the paid people are stressed out. They're totally burnt and stressed out into a fine thread. And even as an ILC and nonprofit, we are passing and giving information on a limited basis on what is true and what we know. If we don't communicate through all agencies locally, because every county runs differently, there's different sets of monies in each county, we won't know. We won't know, and we got to get our community to go and attend these city council meetings or these IHSS meetings and bring them to committees so that they can express these needs that aren't being met or been overlooked, as you stated, Lisa. Over.
Right. Got it. Thank you. Thank you. And Candace in the chat is echoing what you just said as well, saying that most agencies don't know about ILCs and a lot of consumers don't either. So, I mean, that's always been an assignment for all of us to increase visibility and awareness and make what ILCs do known to various partners.
May I say this, Lisa?
Oh, yeah, go ahead.
As you say that each city, we have these ILCs, but the county or the city should know their ILC is there. They should reach out to us as well. I mean, we're a nonprofit. We're not asking for anything or much, but we may need assistance in helping our community help themselves. But we're asking that you reach out to us and let us be a part of this transition, because we can help it be a little bit smoother by giving them options and choices and helping them formulate goals of reality of where they want to go and how they're going to keep this housing when they get it, or how they're going to keep this temporary room when they get it to transition to the next point after the disaster or during the disaster.
Right. They aren't aware that there are independent living skill classes at ILCs, that there's assistive technology available through ILCs, that there are housing staff at ILCs, that is not known in many circles, but it's known more now than it used to be, which is good, but there's more to be known. Vidal, I saw that you had your hand up, but it went down. Did you have a comment or no?
No, I went ahead and just gave my time to my colleague, Mr. House. We work together and we're on the DO network as well. So that's fine. Thank you.
Got it. Okay. All right. Okay. Well, those stories are helpful to get for all of us that are working on this to get a better sense of what's happening statewide and what you're seeing in your own county. So thank you all for contributing that. June, did you have any thoughts or reactions at this time?
Not yet. Just telling Joseph that he gave us a whole laundry list of items, and just a reminder that that's what these calls, like you said, Lisa, are all about. So when you do the poll at the end, Joseph, or by private email, just kind of send us your laundry list of things you'd like us to address, and we'll kind of sort them out and maybe try and prioritize some of them over time. So I think you mentioned enough for us to do this for about 5 years. So you might want to prioritize the list, and we'll take a look. So thank you.
Great. Thank you, June. All right. Let's talk for a couple minutes about shifting from the COVID emergency and the convergence to specifically the homelessness emergency, which I presume no matter where you are in California, it is an emergency. And how can some existing services available through Medi-Cal help us not only help people experiencing homelessness emerge from homelessness, but also prevent people from falling into homelessness? If we don't focus on prevention, we will never dig out from this crisis, because at least where I am, every day that we house 100 people, 130 people fall into homelessness. So unless we focus on prevention, we're never gonna dig out. And we, of course, cannot we cannot solve homelessness. We cannot fix the high cost of housing. We cannot solve wage issues. We can't take on that entire scope of work. But what can we do? And what are some achievable goals for us as this community focused on responding to this crisis and this disaster? What are some tools that we have? How can we raise our voices? How can we better use what might already exist? And what can we push for to better serve our clients and our community? So that's the big question. But there might be a few things going on that we haven't fully maximized, that we haven't really deployed as much as we can. And one of them we've already talked about is IHSS. Are we using IHSS in the best possible way to help people, to help prevent people from falling into homelessness? Are IHSS workers being educated to look for the signs and symptoms? Just a basic example. If eviction notices are piling up on the dining room table, could that IHSS worker, if they have the right education and they're given the right resources, could they possibly make a phone call to refer their client to some program that might offer a subsidy, a housing subsidy, to help them pay their rent? There are some pretty tangible things that we could do, but getting there, that's what we have to figure out, is how do we get there? It's great for me to say IHSS workers should be educated about looking for eviction notices, but operationalizing that and making it happen is more complicated. In a place like LA, where we have, if I recall, don't quote me, but something like 180,000 IHSS providers. I don't know. We have a lot. But in counties where your numbers are more manageable, how can education roll out? How can we work on prevention? How can we get people who are emerging from homelessness connected to personal care so that they are more likely to get housed? How can we really use this program to get people supports to help them get out of homelessness and prevent them from going in? So in LA, I'm modeled on what's already up and running in San Francisco. There's a Bay Area task force on homelessness, on IHSS and homelessness, that's trying to look at this exact issue. So I copycatted that and started one here in LA County, a task force on IHSS and homelessness. Because again, I think these things have to be local, with some state level involvement, but really we have to focus locally on solutions. So maybe you want to start gathering a few people in your own county specifically on this topic of IHSS and homelessness. How can that program, which comes with funding, Medicaid pays for IHSS, how can that program be maximized? And is it being maximized? Are people in homeless shelters, are they being offered IHSS that they're entitled to? Are the right models of IHSS in place to help people with dementia? I mean, there are homeless people with dementia. I mean, it just breaks my heart to even think about that. I work with this program at LA County called Housing for Health. They help homeless seniors with dementia get housing. I mean, it's just so heartbreaking. But there are programs in place to offer supports and services. So what can we do to maximize what we've already got? So are there any thoughts about that? Any questions about that? I see that Vincent has something in the chat about IHSS caregivers and consumers who've lost their workers. Yeah, I think Vincent, there's a lot of opportunity to look at how IHSS is best serving people who need additional supports and assistance. In addition, working with clients who have severe mental illness or serious mental illness presents a whole different host of complications. In San Francisco, the nonprofit IHSS organization, they have about 75% of their clients have a history of homelessness, and a high percentage have a diagnosis of serious mental illness. And so they have to help their personal care attendants understand how to respond to the behaviors and needs of their clients. It's a whole thing that requires just more education and support. So yes, I think that there's opportunity to look at how the program can best meet the needs of really people on a spectrum. So any other thoughts about that? Okay, so there's some, and please just speak up whenever you want or put it in the chat. There's some other Medi-Cal programs that could potentially also help that maybe haven't been maximized. There's something called Medi-Cal waivers. I don't know if it's something. Bye, Joseph. Thank you for joining. I don't know how familiar you are with Medi-Cal waivers. These are programs they're sort of like test programs that Medi-Cal tries out to see if they can offer a different set of services and supports that aren't Medi-Cal benefits, meaning people aren't entitled to them, but they can offer them to a small group of people to test them out and see if maybe they work. And all of the Medi-Cal waivers that we have, there's an AIDS waiver, there's something called the Home and Community-Based Alternatives waiver. There used to be called the Nursing Facility waiver. They're all structured to really help people live as independently as possible and avoid being placed in a skilled nursing facility and help prevent people from going in and out of the hospital all the time. That's what's underneath them. Also underneath them is underneath them is the goal of the state to spend less money, because these programs would ideally cost less or at least cost the same as people having to live in a skilled nursing facility. So But if I were to say the goal of the program, I would say it would be independent living and improved quality of life. That would be a goal. So there's all those different waiver programs out there, but I don't think they've really been maximized for people experiencing homelessness. They haven't really been a priority population. But I can tell you that the percentage of people who are in skilled nursing facilities who don't really need to be there because they don't need nursing home care, but they're in the nursing facility, is because they have nowhere to go. It's because there's no affordable, accessible place for them to go, which means because they're homeless. And they might have been homeless before they went into the nursing facility, and now they're there and there's nowhere for them to go. So they are living in a nursing home. If we had accessible, affordable housing that they could go to with the right support so that they could live independently in the community, they could get out of those nursing facilities. So that's what these waivers are supposed to, in theory, that's what they're for, but they have waiting lists, and I don't think the homeless services community is really clued into how they can get their clients connected to them. And it's just an opportunity to think again about what's already out there that we could potentially help people get connected to, that could help them emerge from homelessness or prevent it from happening in the first place. So Talmadge, I see you have a question. Go ahead.
So thank you. I have a client that is disabled. And speaking of IHSS, I've coached the IHSS provider because I've connected them to. So they depend on me and they help. They depend on our agency and they contact us for information and given them the right way. They've been served with a eviction notice. So, but as I say, each county is different. These transition funds should exist to keep people from going into a home. So, and then with the moratorium in and extended, they still passing out eviction notices with the ending date of June 30th, with the 60-day eviction notice for June 30th. How do we help these individuals? Because we can't go legal as an ILC. We can only extend so much. We can have, they reach out to us for information, and the county limits that service. But there are funds there, and we know there are funds there. How can we help this IHSS provider help their client stay in a safe zone? That's what I'm looking for right now. Thank you.
Well, that is a perfect scenario where there's an opportunity to make those connections, but the people involved have to know where to turn for resources and have to know what questions to ask. So that's a perfect example. Tell me again, Talmadge, what county you're in? I forgot.
I'm in Butte County.
Butte County.
But I also would like to say that I believe that they just released a press that you can file a claim against individuals filing evictions against you. Right? So yeah, I just learned that, which is good, because they need something, but that's just another wait list.
Right.
Hurrying up and wait is just waiting to die still. They don't want to do it this way. They want to continue to live in their home independently. Now they're living in fear of not just losing their place, but losing their care and being placed outside because there's no housing, no accessible housing, no housing that's going to take a neck down chair.
Right.
And they see that and they communicate, they reach out to us, but we're limited in how we can assist them because it goes legal when they say, well, you've been served. That's about it.
Yeah, so I don't know if Butte County has what I'm about to describe, but here in LA County, we have what's called a shallow subsidy program, where people who have gotten eviction notices, just like the one you mentioned, Talmadge, can apply for these subsidy funds. And it's a small subsidy. I think it's a couple $100 a month, but it lasts for quite a while. And for a lot of people, it can be the thing that prevents an eviction. Even because if a landlord raises the rent or if somebody is just short a bit every month, it can lead to them being evicted. So I would say look for that in your own county. See if there's something called a shallow subsidy program. In our county, it's run by our local homeless services agency, and it's administered by Salvation Army. But it's I don't know if it's up and running in other counties. Okay. Yeah, and we see, and Ben in the chat has said that health plans may also have resources. So when you all meet with when you meet next time and you talk about how health plans, the role that they can play in the midst of emergencies and crises, this is something to discuss. I don't know if health plans are going to be on that call or if that's this group coming together to develop more of an agenda about what to discuss with health plans, but that for sure, this is something to discuss. And which leads me to my, I see that it's 11:40, so I want to make sure we have plenty of time for more open discussion, questions. But the last thing I want to let you all know about is that in terms of maximizing Medi-Cal, there's a proposal, a proposal on the table from Medi-Cal to launch something called Cal AIM. AIM stands for Advancing and Innovating Medi-Cal. And some of you might have come across this. It's really redesigning Medi-Cal in a lot of ways to try to make it more efficient and hopefully better. But there's one part of it where the state is allowing the Medi-Cal health plans to purchase services for their members that are not Medi-Cal benefits, but are known to help people live more independently. And there's a set of those services that are housing related. Now they're called in lieu of services, in lieu of meaning that the health plan can buy them in lieu of something more costly and more horrible, basically, like living in a skilled nursing facility or being in the hospital all the time or being homeless. So there's a set of those services that are housing related. And like, for example, there's one called Housing Navigation and Tenancy Support Services. So that would be the kind of thing, Talmadge, that your client could access if they were in a Medi-Cal plan and the Medi-Cal plan decided to offer these services. They would, they could help that person navigate their housing situation. Another one is housing deposits, where the health plan would pay for someone their first month's rent to move into an apartment. Another one is helping people who are housed kind of navigate the landlord relationship. I mean, so let me just say again what I'm saying is that a Medi-Cal health plan, a managed care plan, which traditionally provides doctor visits and medications and hospital stays, could start paying for things like first month's rent, or navigating the landlord relationship, or there's a list of about 13 or 14 of these services, and a chunk of them are focused on people who are experiencing homelessness. Now, the key point about all this is that these services the health plans won't be required to provide these. It's optional. Each health plan in each county gets to decide if they're going to do it or not. And people aren't entitled to these services. There will be eligibility criteria. There's no commitment on the plans aren't obligated to provide them. But is there an opportunity for advocates to work with their local health plans to encourage the health plans to provide these services? If you hear what I'm saying. So that is scheduled to go live in January of 2022. And there are also services on this list, this in lieu of services, that could potentially help people transition out of skilled nursing facilities and back to the community, allow them to live in assisted living facilities instead of nursing homes, or move into subsidized housing and get support services that promotes independent living. There's one of them is for home modifications. So above what Medi-Cal will already pay for, which is some grab bars and some ramps, not a huge number of items, but but the health plans could potentially do more substantial home modifications. So that list is a really interesting list. I see everything on that list as independent living services, including there's one called sobering centers, where instead of, if people are intoxicated in public, instead of sending them to jail, they go to something called a sobering center where they spend 24 hours and then they get connected to support services and substance abuse services. It's a really, it's a good idea and proposal, but the fact that everything on it is optional means that there will need to be advocacy so that these services are launched in different counties. So are there any questions about that? Are any of you involved in any of the stakeholder work groups around this Cal AIM proposal with the state Medi-Cal program? I don't know if you've been involved in any of those work groups or stakeholder meetings. Can you give me a thumbs up or a hand up? And I want to see if you've been involved to date. Okay, so the fact that none of you are in those groups right now, I think means that there needs to be. I don't know. Maybe June. I don't know if it's outside the scope of this group because this is really about disaster preparedness and emergencies. But maybe just like a brief overview of that proposal might be.
Yeah, I was going to ask you a question about that because I think it's right on and it is connecting the dots.
Yeah.
And I have tried to listen to some of the Cal AIM webinars and have gotten all muddled up in the bureaucratic part of it.
Yeah.
So, but the in lieu of services, the way you described it, I think is key. My initial question is, it's kind of like permission to do what some health plans are already doing. Is that a fair statement? I mean, I've experienced working with some health plans. They're already doing some of this. So is that true or not?
Yes, I would say some health plans are doing some of this, but if they are, it's not, they're not getting financial reimbursement from the state for doing it. They're just kind of paying for it out of their own pocket. So that's the key difference, is that if a health plan purchases these housing services, the state will pay them back for those services. Whereas right now, if a health plan pays for housing navigation services, they're not paid back for it. They're just investing out of their own pocket, which is great because they probably see, well, helping someone get housed, it might cost me this, but it'll decrease the number of times they end up in the emergency room. I mean, it should, at the end of the day, it should even out, but there has to be an incentive. There has to be a financial incentive for the health plans to do this.
Yes, and so the key question that's really helpful is the key question is, will the reimbursement be sufficient? I mean, there are plans around the country, a few of them, not many, who are actually contracting with independent living centers to help people transition out of nursing homes. Like what you spoke about before. Very few and far between, but they do exist. So I guess my question is, do we have any sense of, will that reimbursement be sufficient enough for the health plans to be open enough to contracting with, say, independent living centers or other community-based groups who have the expertise to do this and do it well?
That's the question. I don't know the answer to that. There haven't been any details released about what the reimbursement will be, what the incentives will be, how the financing will work. But one of those in lieu of services is nursing home to community transition. And it would allow the health plans to pay some entity to identify people in skilled nursing facilities who could get out and help them move to the community. Which is good, which is essentially what the Money Follows the Person program is, the California Community Transitions program. I imagine a bunch of you have contracts to do that already in your counties, that program, CCT, California Community Transitions. So it's kind of modeling that or duplicating that. So then the question is, well, is it replicating that? Is it the same? Is it different? We don't know that yet, but that is one of the services that's listed in this CalAIM proposal is nursing home to community transition services, which means it's an opportunity for an organization that has experience doing that to potentially contract with the health plan to do it for the health plan members.
So Lisa, is there, you mentioned work groups. Is there a work group that specifically deals with in lieu of services focus?
There is. It's by invitation. The stakeholder meeting, the members of that stakeholder work group are invited, but the public can attend those meetings and monitor and listen and submit questions. And it's all in the Department of Healthcare Services website in the CalAIM section, CalAIM section in the Department of Healthcare Services. So, and if we think about the idea here is that, how can these Medi-Cal programs help the homelessness emergency, and how could they have helped in the COVID emergency? If some of these services had been in place, these proposed in lieu of services had been in place when COVID hit, could we have been more nimble? Could we have more quickly responded and helped people avoid the worst outcomes? That's a question too. I mean, if we had more tools in place to quickly get people out of skilled nursing facilities, could we have done that when they were the most dangerous places to be over the last year? Yeah. I see Vidal's asking a question about whether the CCT program has been refunded, and I believe the answer is yes, Vidal. I can't remember when it was extended to, but that's funded by a federal program called Money Follows the Person. The last time I looked at it, it had been extended, but I can't remember until when. Maybe somebody on this call knows. Yeah. Okay. Kelly has some in the chat. Kelly's saying if anyone would like information or resources regarding helping individuals transition from institutional settings back into the community, Kelly has listed their email address in the chat, so you can reach out to Kelly. Any questions or thoughts about what we just talked about, which are this Medi-Cal, this list of proposed Medi-Cal services that health plan would potentially pay for?
I would like to say thank you. I appreciate the information, and as I'm looking it up, and in lieu of services, the website on the health services, it's short, but it gives you enough information on how to get into the group and things like that.
Good.
I will follow the advice that you gave me, because just trying to give them information, I got barriers that I have and boundaries that I have, but I'm just trying to provide them as much useful and helpful information without sounding like I'm slamming a door and just passing the buck. So, thank you.
Sure thing. And Talmud, you saw Sherry's comment about how Butte County might be participating in the Home Safe program?
Yes, I did.
Okay,
Thank you, Sherry. I appreciate that. I noted that down too.
Great. Yeah, we have that same program here in LA County. Thank you, Sherry, for bringing that up. Comments, questions, thoughts? What is the assignment to this work group based on our discussion today? What do you all see your next steps on this topic?
More education.
Okay.
I think, Junior, I want to dig deep into this CalAIM in lieu of service work group and make sure that it can be as real and specific and well-funded as possible. So it's not just in name only, but it really works.
Mm-hmm. Okay. Anyone else? What do you think in your own communities, in your own counties? Did this bring up any thoughts or ideas about some concrete steps you could take locally to be better prepared in the future? Anybody? I'm sure you're thinking hard. Well, I know that the ongoing work of this work group, I know that will continue to move towards preparedness. I mean, that is the goal, right? Is to be prepared. I mean, we're still in this emergency. We're still in a COVID emergency. We're still in a homelessness emergency. We're still in emergencies of poverty, emergencies of racism. But we can make some progress, and we can do better. And as we saw, we had some successes, even in the midst of this nightmare. We had some successes. So I will say for now that I am going to wrap up, and I'm going to turn it back over to June and Megan and see if they have any final words or final thoughts. Thank you all for inviting me today, and I'm really glad that I could be part of this. It's good for me to hear what's going on with all of you around the state. It helps me get my gears spinning and thinking about how we move forward. So thank you.
And Lisa, June, thanks for helping us look at this in a deeper way. I think it's very helpful to have that kind of discussion time. But you all don't hang up yet. We're not done. We've got a poll for you so we can get your feedback, and Megan's gonna put that up. But I do want to thank Lisa formally for helping us to do a deeper dive and to really take time to hear from each other and think about our personal and group next steps. So thank you, and all of you. Thanks for the privilege of your time and your participation. And now your feedback. So
This is Megan. Unfortunately, when I go to launch the poll, I'm getting a message that I'm logged in from another device and our polling session's inactive. So I cannot launch the poll, but June did share it in the chat, and I'm going to go grab that link again and share that poll link in the chat. It is a SurveyMonkey, so if folks can take it, it's just, I think, about 6 questions. It shouldn't take you more than a minute. Please go ahead and fill that out. I'm sorry, I can't launch the poll right now.
Oh, you didn't say your technology prayer.
I didn't. I missed that this morning. I'm sorry.
Well, thanks again, all of you, and give us your feedback. And Lisa, a big thank you to you for helping us unpeel some of this complex issue. So you all take care, and bye for now.